just
Everybody.
because oh, sorry, what?
We're live, Jaron. And so Jaron and I were just talking behind the scenes on like what to talk about with a really difficult subject of expanding our role and focus. So Jaron has a few talking points to go through. We'll kind of break down what has our previous role been inside of the pharmacy world and what have both of us seen, and then what are some of the expansions and why are those kinds of things happening kind of at this juncture of pharmacy and healthcare. So we'll play the reel and we'll be right back. Jaron, so good to see you, buddy. I know we both had kind of a crazy day, and then we just kind of flopped sideways into the episode. But thanks everybody for joining. Really excited to have you guys here. Jaron put out a post kind of asking everybody, what do you want us to talk about inside the rebranding pharmacy number of shows that are coming forward? And then do you want to join us and be able to talk about some of those things? Please feel welcome to send your insights and your perspectives, because I know there are a ton of pharmacists out there doing really awesome stuff that more folks need to know about, and the reason why they're doing it and how effective it is. And so there's the invite there for a high level of participation, because we want it. But Jaron, when it comes to a high level of participation, I've only seen three things in pharmacy school. It was go into retail, go into hospital, go into maybe industry or ambulatory, depending on which one you're looking at. And those were the three tracks. And when you got into them, interesting thing that Thea and I were talking about is you didn't have to do anything else, Jaron. Like, your job was already set up. It was literally you get out of this seat in your pharmacy class and you sit in this seat in your new occupation. So there wasn't a whole lot of change. The only thing was maybe some vertical movement when it came to managerial positions, or maybe some clinical specificity related to a residency, type of tract. But that's what I usually think of, thinking of a pharmacist role. And then going even more brutal than that, you hear the word and it drives me nuts, but white coat, it's just cringy, to me, of using those kinds of terms to describe our profession. The number of times I've worn a white coat, I can probably count on one hand, and most of them were related to pharmacy school and graduating, from it. And that's about it. But anyway, going through all those, Jaron, what do you see changing, buddy? And what are the forces that are making them change?
Yeah. So obviously, we're the gap of providers that are needed versus what we actually have is growing daily. And there's been some efforts to correct that with, cranking out more NPs and stuff like that. But I know I'm beating a dead horse when I say this. Pharmacists are a more logical person to fill that gap, and we don't even need provider status. We can just do more collaboration efforts with physicians and team up with them for more billable opportunities. And my perspective tends to always be in the long-term care and skilled nursing side. But one of the things that is a big problem is that soon we're going to have more residents in need of long-term care, more of those than beds available to treat them with. So that's why there's going to be a big push for long-term care pharmacy at home. And there's a lot of push, a lot of work being put in that to make that work, so that we can have consultant pharmacists providing consulting services for people who are getting long-term care from home. So they'll get prepackaged pharmaceuticals and stuff like that. But they'll have somebody reviewing their meds every month, just as if they were in a nursing home. So that's kind of stuff that's coming down the pipeline. And I think there's a lot more we could do besides that, because once again, we're going to be, if that's the case, we're going to be structuring our clinical services around providing a product, which, as we talked about last time, there's a bit of you're always shortchanging one or the other when you combine them. And there's possibilities, and there's always exceptions to that rule.
Sure.
But generally speaking, it's going to create a lot of conflicts, and it won't reach its full potential. So those are the things that are kind of coming down the pipeline that will make a big difference as far as how healthcare needs us to adjust and to recalibrate, so to speak. And we have the training to bring something new to the table that other providers don't have. And that is what sets us apart. And if we don't utilize what sets us apart, we are totally replaceable. And so now it's time for us to start utilizing that training, start to make sure that we're not overlapping our services with what is already done in an EHR, not regurgitating prepackaged data from drugs.com. It's always a line I drop, but those are kind of what we're looking at right now. It's time for us to adapt with the need of healthcare. It's time for us to utilize what makes us unique, what makes us special, and most importantly, what makes us a powerful advocate in patient care.
I think you said it perfectly, buddy. I mean, I think that the pressures that be are very interesting right now inside of healthcare because the expenditures are high, the results are low in general. Like we're trying to find ways to take care of even more people who have high levels of chronic complexity in a healthcare system that was made to address acute concerns, right? And so we're really shifting models back and forth. There's a lot of subscription-based elements that are happening in the direct primary care models. You're seeing more and more even pharmacies look to subscription-based models to be able to care for their individual patients and to avoid some of the margin-related pieces inside of their product modalities. You're seeing healthcare in general look at value-based care models and seeing more and more Medicaid systems offer value-based care. And for us, like for pharmacy in general, playing the game, like being inside of the space, Jaron mentioned it right off the bat, there aren't enough providers to go around. You know, Richard Harris gave a presentation inside of our PH Ally soiree and talked about, you know, the real brutal truth of the fact that we just won't have enough primary care physicians. And there's an interesting surplus and accessibility of pharmacists. And that's one thing that's always driven me nuts, Jaron, is always saying like, we're the most accessible healthcare provider. Are we? You know, that statement in general, it's not true. Like it's saying that there is someone there, but we're not filling in the capacity of what we could do from a healthcare provider standpoint. We've talked before about even in the fee-for-service model, which we're starting to see a shift away toward value-based care, even in fee-for-service with incident to billing, you know, and the capacity for us to, it's not going away. We're adding on additional fee-for-service models. We're trying to start navigating those fee-for-service models toward chronic care management. You're seeing more money being put in there. And so with those things being said, that's the place right there where pharmacy has to be not only accessible, but have the acumen to be successful.
Yeah.
For
yeah. And, you know, and you know, it's funny because technically speaking, yeah, we are more accessible than other healthcare providers, but because of the way things are structured and the way pharmacists are paid and the employers that employ them, because of this foundation and the structure we currently have in place, we're accessible, but it's a burden to us. It's hard for us to feel good about dedicating time to being accessible because that pulls us away from our daily needed and necessary tasks just to barely stay afloat with all the tasks we have to do. And so, yeah, we're accessible, but not nearly to the level we need to be because of the fact that it is just a massive burden to pull them away from their tasks.
Yeah,
and interrupt their daily work.
And when it comes to just expanding our role and our focus, I think that's really it. We talked about last week, kind of looking at our focus of having a very strong product focus, all the way from our educational rearing toward the stereotypes of what is a pharmacist is very product focused. And so I think now when it comes to expanding our role, it is significantly related to how do we help these individuals with complex disease states and leverage our ability to navigate through this decision-making capacity to say, this is the best next step for this patient. Here's the next best monitoring tools for this patient. Here's the next implementation of a program or a software or whatever the case might be for an individual patient. How do we get that in place, Jaron? Like, we know that this is the new shift. When there's an expanding role in pharmacy, what are you seeing where people are expanding their role and how are they doing it?
So there are a lot of great things happening out there. Unfortunately, a lot of us are operating in silos. We're not really doing a lot of work together and combining our efforts to make great things happen. I think that will come eventually, but for now, I think that's kind of a necessary step for us to kind of start building stuff independently and then slowly building them to a point where we can start kind of teaming up and making greater things happen. But there's a lot of great people out there. Amina Abubakar, she's got her own pharmacy in North Carolina where she does a lot of clinical services and has her pharmacists going into clinics with physicians and doing a lot of billable clinical services. We've got Jenna Quinn, who left the pediatric hospital space to set up her own clinical services in an ambulatory setting, as well as I'm not sure if she's consulting in hospitals as well, but eventually, yeah, she's going to have a powerful stake in the market with the stuff she's working on. And, there's lots of others. It's funny because I get pharmacists reach out to me for input or whatever. And probably my most common thing that people reach out to me for is PGX. Pharmacists really want to find out how to make that space work, how they can apply into the long-term care space, because there's a lot of private pay models, cash pay models in place with PGX, but that kind of limits your market. So we need to find a way, and that's what we need to do. That's the game we have to play to start that process. But eventually we need to start tracking that data so that we can start bringing that to payers and showing them the benefits. And Jamie Wilkie does a lot to train people on PGX as well. She's also a great advocate and doing a lot of great things for pharmacy. But there's a lot of work to do in PGX, and I think it would be amazing if eventually we have a system where, a physician makes a diagnosis and they go to the pharmacy and say, here's my diagnosis and here's my genetic profile. Just where do we go from here? And maybe genetic profiles will eventually replace an allergy list, because that would be more beneficial to tell us actual allergies, as well as how they respond to each individual medication class or whatnot. So a lot of great things that are happening right now. And we need to start working together now that we've started to build them.
Yeah, I think if we can kind of bucket some of the things where we're seeing some expanded roles, we're seeing some folks take advantage of their positioning in community. And so they're partnering and they're doing collaborative practice agreements, or they're trying to move people into OTC-based or cash-based models that are using their clinical services there inside of the community pharmacy type of setting. We're seeing individuals that are doing direct to individual institutions. So they're either working through a collaborative practice, or they're working within FTAGs or other specific guidelines to take care of individual necessities for these institutions, if that's a SNF or an ALF or a senior care center or whatever it might be. We're seeing other individuals that are taking advantage of incident to billing capacities. They're saying, hey, there's already the ability to bill for these services, and I'll take a percentage of that from the physician that I'm billing under to be able to work with them. There's more that are doing something and creating their own positions. So they're leveraging that I can provide these elements. I can affect these quality metrics. I can decrease the burden on these individuals, and therefore I'll have a salaried position within this institution or another. And so those are the ones that I'm seeing most often, Jaron, like in those types of buckets, the way those folks are kind of working to expand their roles. But you hit on something that I think is really essential for us to kind of recognize. When we graduate, we talked about going from seat to seat. That's something that's just so comfortable, Jaron. Just being able to graduate and be done and feel like, hey, I made it, now I can get a paycheck. For the knowledge I have, I can leverage it and get the paycheck. And when there's a direct transition that you have, even recruiting happening at the college level for someone to come and work in these settings, this hospital, retail, and or ambulatory setting, we need something along those same lines, Jaron, at that kind of scale. I truly believe for our profession to have a navigation from where they are inside of the didactic university setting and be able to transition to be able to work with Jaron, right? At that kind of scale and level, that they have these types of clinical programs that someone would graduate and go, I'm going to be able to be a pharmacologist working with these individuals doing these types of things, and have a standard of living that is not a gig-based economy, but have the amount of work coming toward them that they know they're going to be able to work at scale. And I think that's the divide for me, Jaron, when it comes to that, like actually happening, is policy, right? For us to actually see some policy go in place, because reimbursement, if we like it or not, is a big factor. And I know some people, they very much so dislike the provider status conversation, which, I can see the pros and cons. But when it comes to being reimbursed for our services independent of other practitioners and having the ability to flex our pharmacologist muscles, that's when I see one of the biggest burdens to scaling the pharmacy profession in this expanded role space. What are your thoughts on that, buddy?
Yeah, I think that is one of the biggest issues we have. And, provider status is a massive, massive leap from where we are right now. It's just, It's not something that's really can be palatable for healthcare or CMS in general. It's not palatable by the American Medical Association. It's too big of a leap. So we need those stepping stones. And as much as we would like to flex our independent pharmacology muscles, for now we have to take those stepping stones that are here in our path right now. We have to utilize those Incident 2 services. We have to collaborate with physicians so that we can be paid for those services. Now, we do have some obstacles because Incident 2 isn't going to cover everything. It's not a Medicare A service, so it won't work in hospitals. And that's a bit of a barrier because in hospitals, ironically, that's where we've utilized collaborative practice agreements the most.
Yep.
However, I think it's time we start expanding the use of collaborative practice agreements in hospitals because historically it's just been confined to vancomycin dosing and warfarin or anticoagulation dosing. I think we can do a lot more than just those two areas. And there's a lot more things we need to do to expand those collaborative practice agreements in hospitals. But once again, the barrier we have in hospitals is that until we prove ourselves, we're always going to have that barrier of how much time can we dedicate to a pharmacist providing rounding with the physicians in the ICU? How much can we dedicate a pharmacist sitting down in the ICU doing clinical services day to day? As long as we are linked to a product without the ability to bill for time, we are very limited in our ability to expand our clinical muscles and show and prove our value. So we have to utilize those collaborative practice agreements. And sometimes we just have to spend a little more of our time and capital into proving our value. So, I mean, in a nutshell, we just have to take what is in our path right now, make the best of it, prove our value, and then eventually branch out into the inpatient setting where we can, do potential services similar to Incident 2, but we can't do Incident 2 there. But eventually, I mean, I guess in a nutshell, just prove our value so that we can eventually start having more billable opportunities once people recognize our value.
Yeah, and I think when it comes to any practice, even outside of healthcare, if you're trying to be a part of the team and get paid for that team element, if you're looking at the individuals going to build a house, right? Building a house, you got to put in plumbing, you got to put in electrical, you got to have carpentry to put up walls and et cetera. Everybody has a role. Like they're taking something off the overall burden of creating something. And I think that's a real identifier there for pharmacy. What are you taking off the table for everybody else? Like where is pharmacy really putting their foot in and saying, we're taking this and we're going to own this element of care in the institutional setting. It's not we're just coming behind giving advice, because you can have a supervisor come behind and give advice and give best practice recommendations, but someone to be able to take some of the care burden is something that I think we haven't carved out a role well enough outside of doing rounds, that sometimes the question even comes about. And Zane talked about this today or the other day. He said, a practitioner told him once, I loved having you guys here. You give me great kind of insights, but what do you do after rounds? Like what are you doing? Like, what is the activity? He was trying to champion pharmacy. Like, what more can I have you do for me kind of deal? And so I think it's interesting that we haven't taken that role, like been able to say, we're going to do the monitoring, the lab processing, everything to do with medications, pharmacists are going to own, like that individual space. And without that level of ownership, it's like, well, what am I giving you to do? Like, what are you really taking off my plate or my table for you to take care of for me? And it's perfect because you mentioned hospital, where we know that that's already happening to a certain extent. If we can take that exact hospital mentality, because the reimbursements there, Jaron, are somewhat value-based care-ish, right? So we're getting reimbursed in a critical access system in a cost-based reimbursement. We're getting reimbursed as a DRG or a diagnosis-related group inside of these systems. So now when we shifted over to value-based care in the outpatient setting, instead of having the provider status have to be thrown on, we can be part of a care team, right? That can be reimbursed as part of that pie. But what part of the pie are we taking care of, right? What are we owning inside of that space if we're not our own provider? And I think that's the piece of expanding our role and focus. So what do you think we have to own, Jaron, when it comes to, the full scope and picture of care that pharmacists have to be responsible for?
Well, we've proven time and time again our value in chronic disease management. And I think that's kind of where Amina Abubakar started her clinical services career, was offering assistance with CCM billable services in physician clinics. And that's kind of where she started, and it kind of branched out to several other opportunities and services from there. And, there's not a lot of wiggle room in the reimbursement for CCM. So, I mean, it's a great place to start. And you have to kind of get creative, because it's hard to justify all pharmacist time when you're doing CCM services, unless you break it up and have, pharmacy tech or medical assistant doing data gathering and stuff like that, so that we're not bogging down the pharmacist, so they can do more assessing and analyzing. But I think chronic disease state management is a huge point that we've proven time and time again that we are valuable in doing. So that's kind of where it all branches from. And when you look, the things that we should absolutely own is chronic disease management, as well as what I had it in here. Oh, polypharmacy. We need to do a massive amount of education on polypharmacy. Right now, I think the general population just thinks the more pills I take, the better, because they're helping to keep me alive. And now we have a lot of data. If you just go to the Optum website, you'll see a lot of data about polypharmacy and its detriment. And so we need to start educating people that, hey, here's some lifestyle modifications that can reduce your medication load and improve your outcomes. Ironically, we as pharmacists need to reduce the use of medications. And, a lot of people will think that's bad for our profession, but now think of it like this. Now we're able to profit from dispensing a medication, and now profit on the other side of having a pharmacist perform services to identify what meds are no longer needed. So we can benefit with both the dispensing of meds and the elimination of meds if we're able to bill for our time to do that kind of service. So just think of that as a good aspect for our profession in general, when we're able to bill on both sides of that transaction. And last of all, I think it's really funny when you think about in an outpatient setting and in a retail community pharmacy, if you want to transfer your prescription, it has to be transferred by a pharmacist to another pharmacist. Some state laws may be getting more relaxed in that regard, but if a patient is going to transfer from a hospital to a hospital, or a hospital to a nursing home, or a hospital to home, that doesn't require any pharmacist input. And that's a big frustration for me, is when I see a list of meds coming from a hospital, it's a nightmare. And if we had pharmacists putting in their attention to detail in that med list, doing medication reconciliation and transferring these med orders from one setting to another, that would make a huge impact in simplifying and making sure the meds were appropriate and the duplications were removed before they're even dispensed and become a potential problem. So it would prevent a lot of issues that are already happening. And so that's kind of my trifecta. A lot of reconciliation that involves a pharmacist to another pharmacist, so that we all understand and are on the same page. Chronic disease management, and what was that other one I said again?
Deprescribing or optimizing.
Deprescribing, yeah, polypharmacy. That's and Dylan Canterbury is amazing. He does a lot of work in deprescribing. He is a huge advocate for that, and he's a a good contact to have for that. So,
Yeah,
and we need more pharmacists to think like that.
Bartlett. Yeah, I think there are a lot of folks that are, doing those kinds of things. And if you had a geriatric residency, I think you start to really embrace it. Or if you just love geriatrics, you start to understand why it's so essential. But regardless, I guess I'll say, Jaron, for a couple cents in there, I don't think that we really have to reinvent the model to expand our role. I think our role has already been expanded, but it's just been done in a couple silos that not everybody sees. And in the IHS system and inside of the VA, the pharmacist role has already been expanded, and it's been expanded for 20 plus years. And we're seeing pharmacists that are acting as chronic disease state managers inside of these systems to be able to take burden off of the individual prescribers and focus on disease states that they can order labs, order testing, follow up on all those things, do prescribing, do changes to order management. Like all of these things truly take stuff off the table for the rest of the healthcare team not to worry about. And I feel like that's one thing that we have to get to that point, because unless you can do it all, you're putting more burden back on someone to have to look over your work or do the other things that you should have done.
Yes.
You're taking. So I feel like those are really good examples of folks that already are doing these types of things. We just need to mechanize them inside of other healthcare systems and leverage it in either value-based care models or leveraging a salary based on quality metrics to bring pharmacists inside of those settings. When it comes to the scale and scope inside of community pharmacy, it's an interesting, piece that I read an article and watched a little clip the other day on having different roles for different people in an organization. This was on nursing in particular. And it was looking at which nurses are going to be best for data entry and for doing these certain tasks, right? Taking some burden off those that are bedside clinicians. And then who are also the nurses that are going to be best to start breaking down all the inefficiencies that are potentially happening or where the errors could occur in a workflow. So there's several individuals with all very valuable skill sets. And there's nothing wrong with a profession starting to say, some of these folks in this profession do these things. Some folks in this profession do other things. I feel like oftentimes we want to all be experts in everything. And I'll be the first one to admit I am not an expert in everything. There's very few things that Kevin's an expert in, in just general. One thing is obviously not speaking about myself in third person, but I think all of those aspects will really help our colleagues and our entire profession recognize that, one, you really have to find a way to leverage what has already been done and the billing mechanisms inside of those spaces that can allow you to do those similar things and take the burden off the rest of the healthcare team. Because if we can do those types of things, you and I both know, and all the other colleagues out there know, that once you're part of one of those clinical teams and you're doing those things for them, they would never, ever want to practice again without you in their space, because you make such a big difference and your knowledge is so much more unique than you even think. There's my 2 cents, Jaron. Anything for us to end on with our expanding our role and focus?
And I think you're right. There's a lot of things that we can do that this doesn't require an overhaul right now, because there's a lot of stuff that we are already doing that we need to do on a larger scale. And I think one of the things we need to do is start communicating with each other and start sharing best practices. And that's kind of why, like we mentioned last week, that we're putting together this symposium in November sometime. And I'm hoping to finalize more details in the near future. But we need to get more of these great thought leaders in a room. We need to get them all to share ideas and best practices and start teaming up and making bigger things happen, and making our impact more noticeable. And unless we start communicating and collaborating and working together, we're not going to make the impact that we are capable of making. And I think that's kind of where I would like to end it.
Yeah, no secret sauce, no silos. I think that's where it has to go. And we have to be able to say, this is exactly the roadmap that I went down, and be able to bring more people along that pathway, I think is really essential. The other piece with expanding our role that I'd like to plug in there is expanding our role isn't on our own backs, unfortunately or fortunately. Like, we have to be able to collaborate with physicians, nurse practitioners, all the other colleagues that have the prescribing authority and the ability to bring us into their individual spaces and expand our roles, they're going to be a big factor in making sure pharmacists are fully leveraged. And so I think making sure that we're reaching out to those colleagues and getting this kind of information to them related to what are we doing? How well is it working? Why is it successful? And how is it being integrated into other systems is just as powerful and impactful to scale, what we're trying to do. But anyway, Jaron, like always a wonderful conversation. Folks, if you're listening, thank you so much. We really appreciate you guys being there. We look forward to hearing more about the awesome things that you guys are doing and telling Jaron and I what else we can talk about, things you guys would like to join the show and be able to talk with us about, or just educate the pharmacy world on the amazing things that you're doing to impact the next generation. So we will see you guys next week for another topic. And what's next week, Jaron?
Next week, I forgot. Let me see here. It was...
Looks like meet the needs of the healthcare of today and tomorrow. Okay, awesome.
Yeah.
So we'll look at some of the bills that are coming up and some of the legislation that is kind of on the docket of what is happening throughout the rest of space and kind of propelling us into these next steps. So really excited for that. You guys have a great rest of the day.
Thank you.